Thank you for allowing me to speak today to Erlanger. I'm Dr. Jake Mckay. I'm our main epileptologist on the neurology side. I'm excited to share with you all today a bit more about epilepsy. This is a general overview intended for all physicians at Erlanger, in particular non-neurologists. I'd like to tell you a little bit more about epilepsy and also kind of what we can offer. I have a few, well, really only one possible disclosure. It's not even a real disclosure, but I may eventually give a talk for the company UCB. I never have received any payment from them and have not spoken for them in the past. All right, so here's an overview of the talk. We're going to discuss the epidemiology of epilepsy, more about what it is, the types of treatments available, and then we'll jump into the different types of focal epilepsies. This is important to know because they can manifest very differently, and an astute observer may be able to pick up certain epilepsies by knowing what the less typical epilepsies can present as. I put this quote in here by Titus Lucretius Carus, Roman Epicurean philosopher, to show epilepsy has been around for a long time. It's not something new. Throughout human history, it's existed, and we'll come back on that. But this is just to give some perspective. So the first question, though, of course, is what are seizures? What are epilepsy? And they're essentially excessive electrical activity in the brain with synchronous firing of neurons or brain cells. There are networks of connections with brain cells and neurons that form the basis of epilepsy, that once they're turned on, the brain may struggle to turn them off. And there are many reasons that can occur, which we'll get into a little more. And epilepsy specifically is a man-made, mankind-made definition that is very specific to medical jargon. It doesn't mean just a seizure. It has a specific meaning that patients have repeated unprovoked seizures or have a high risk of frequent seizures based on testing. So the definition of epilepsy has actually changed somewhat over time, but now the definition is defined as two unprovoked seizures occurring within 24 or more than 24 hours apart. So if you have two back-to-back seizures, within an hour, that doesn't qualify someone as epilepsy. There has to be a division in time. Or a patient has to have a single unprovoked seizure in an abnormal EEG or an abnormal brain MRI. That would also qualify someone for a diagnosis of epilepsy. And the reason that is because the probability of them having future seizures then becomes quite high. And that means they're going to have over a 60% chance of a seizure going forward. So the epidemiology of epilepsy can vary depending on the sources you look at. But in general, it's thought to be about 50 million people globally suffering from epilepsy. So it's quite a large number when you really think about it in the aggregate. And focal epilepsy is definitely the most common cause of epilepsy overall, and also in adults, very much so. Stroke being the most common cause as people get older, but there are many possible causes, which we'll get into again a bit later. And there's probably actually a higher than 5% chance of seizure after a stroke, probably more around like 10% long term. But there's certainly a risk of seizure after strokes. And to put it in the perspective of neurology a little bit, epilepsy is the fourth most common neurologic disorder. And, it's kind of unique in neurology that it really affects people all ages, it can be from a neonate to someone who's in their 90s. So here are a few just brief diagrams that show kind of the burden of epilepsy, and it tends to be around 1% of the population in the United States, and maybe a bit higher than that in certain developing countries where they have a higher rate of the pork tapeworm and sort of those kind of factors that may play in from the infectious disease side. So there are different types of seizures, and I wanted to get that out of the way early. Focal onset seizures begin in a specific area of the brain, And this is the most common type of seizure. Now, the presentation can vary tremendously depending on which part of the brain the seizures start in. About 66%, so the most common location of a focal epilepsy is within the temporal lobe. And that's kind of the stereotypic type of story you're going to hear is, about temporal lobe symptoms. But there may be other locations that have very different manifestations. Generalized seizures are not actually starting kind of the whole brain at once, like you hear in medical school or whatnot. It's actually a diffuse network, though, between the thalami and the cortex. And so it appears to be that way on testing when you look at it. But essentially, the type of seizure matters very much because there are actually different ion channels which can be involved based on whether or not a seizure is focal or generalized onset. In medical school, we've kind of all heard the partial and generalized terminology, but it's decades old. So I wanted to hit on that today as well, that essentially the modern terminology divides it into focal and generalized onset seizures. And then you take it a step further with focal seizures. Are they aware or do they have impaired awareness? And then you can really break it down from there. Is it motor or non-motor? So someone who just stares but can talk to you is a focal, aware, non-motor onset seizure. And so that's a more specific way to describe seizures. And that's really where the terminology has moved. And so the partial onset and whatnot is kind of, in my opinion, quite outdated at this point and not very descriptive. So this is something to think about, using as we go forward. And within neurology, I'd say it's pretty much it's taken hold. It's been about 4 years now since this came out and it's becoming commonly used. So going back to different seizure types, just a brief overview, and we'll delve into this more. Temporal lobe seizures often begin with deja vu, bad smell, a weird feeling, staring, picking behavior, and this type of thing is what you're going to hear with the typical story when patients tell you about seizures. It's probably something you're all familiar with. It can sound very odd, though, when people first describe it. So you have to keep an open mind to what they're telling you. When you hear this kind of weird feeling, this sensation that comes over them, keep in mind this can be an early kind of aura symptom of a temporal lobe seizure. Now, on the other hand, the generalized tonic-clonic seizure is kind of the Old Testament variety seizure with rigid posturing of outstretched limbs, followed by rhythmic shaking of all four limbs. And this is commonly associated with loss of bowel control, bladder control, lateral tongue biting, that sort of thing. And then absent seizures are staring, spells, lapses in awareness. They may have eyelid flutter. They're typically brief. In kids, you might actually be able to provoke them on the spot with hyperventilation. And this is a very specific type of seizure. So, I just put it out there that it'd be very unusual that an adult would come in, at age 50 with new onset absent seizures. Generalized epilepsies can happen later in life, but it's generally quite rare. You're most likely dealing with a focal seizure in that type of context. So when you have a patient come to you with those sort of symptoms, what are the next steps in epilepsy testing? If you send them to neurology, what kinds of things will be done? What can you anticipate your referral resulting in? Well, basic labs will always be obtained unless they're coming with the patient in a form of outside record or something like that, or already in the chart. And the most typical thing that will be obtained is an EEG. Electroencephalography is sort of the mainstay of epilepsy diagnosis. And that is a brainwave test that you're measuring the brainwave activity to look for signs that the patient has a high risk of seizures going forward. If you don't get the answers with the short-term testing, sometimes you do have to move on to ambulatory EEG or the epilepsy monitoring unit. Brain MRI is very essential to epilepsy diagnosis because if you have certain changes in the MRI of the brain, that may also be indicative of a high risk of epilepsy. And there's more advanced imaging that's typically used more at surgical centers and things like that that are going to be like PET CTs of the brain, SPECT scans, but we won't go into that too much. Here's a picture of, it's not our lab, unfortunately, but this is a picture of someone getting an EEG done. And what they might expect, having electrodes on the head, computer recording. Here's a picture of an epilepsy monitoring unit. This is Cleveland Clinic's, unfortunately not ours. I put a little image of Erlanger East out there too. And so this is what a lab may look like, where you're going to be watching several patients all at once. So what are you exactly even looking for in an EEG? You know, that's always a question. And one of the first things you're looking for are epileptiform abnormalities. And here's an example of a common one of a sharp wave. And you probably can see in this left temporal region that there are these abnormal kind of discharges that look very sharply contoured. And this would be an example of a sharp wave discharge. Here are some further examples of sharp wave discharges. Now, not everything that sharp's an abnormality, but this would be kind of a classic example. And a seizure, however, may look quite different. And sometimes we get lucky and we capture a seizure on EEG. A seizure would start with rhythmic activity that then evolves. I think I could convince you that you see there's some kind of change to the EEG here, which you don't really see and everywhere else. It's sort of here on this part, and then as it goes, it sort of starts picking up an amplitude, frequency, and it starts to change in how it looks, and that's called evolution, and that's what's very commonly seen in a seizure. And you have to fulfill certain criteria of evolution to make it really fit the definition of an electrographic seizure on EEG. Here's another brief example of one that's a bit more subtle, that starts again in the left temporal lobe on this example, and you see that it's a sort of this rhythmic activity that then starts to get slower and spread out across different electrodes, and that would be an example of a seizure. So once you know someone has a seizure, you know you're going to want to treat them, and so that's something that we would do if we know they have a high risk of future seizures. They fit the definition of epilepsy. And seizure drugs in general, anti-seizure drugs, are about 2/3 effective to totally get rid of seizures. That may require a trial of more than one medicine, potentially 2 medicines. But that's always the first sort of step when you're treating people. If that doesn't work out, what happens to the 1/3? Surgical devices or actual surgical resection can be a very good option for many patients. And often people wait quite a long time to refer patients for this, when really they probably should realize after a couple medicines that it's probably a good idea to send them on to an academic epilepsy center for pre-surgical evaluation. I also put mind-body exercises. I think involvement with the community, meeting other people with epilepsy, being involved in alternate strategies to keep a calm mind is very important and very helpful. So seizure medicines have been around really since 1912 with the advent of phenobarbital. Anti-seizure medications affect how the neurons fire in the brain by working on various ion channels or neurotransmitter signaling. Now, the purpose of these is to stop the brain from firing too fast when there's a seizure, but still allow the brain to fire and function otherwise. You know, you can't have someone totally sedated. People have to be able to function and live for this to be a worthwhile treatment. And that's something that's, you know, come a long way. Here's an example of phenobarbital through the ages. You can see it's now got a nice modern vial on the right, but it began sort of, you know, same exact medicine, it's just been through a lot of iterations. Now there are a lot of anti-seizure medications in the modern era. You know, you're talking 20 or more. And here are some common ones. I just point out with this slide that anti-seizure medications don't work for all different types of seizures necessarily. Some are broad spectrum, like our good friend levetiracetam or Keppra or lamotrigine. Others, like ethosuximide, are very, very specific for a certain type of seizure, in that case, absence seizures. Oxcarbazepine, trileptal, very much a focal seizure medicine. So keep that in mind with your selection. If you don't really know what type of seizures people have, you may have to initially start with a broad spectrum agent. That's one of the reasons I think it is so popular to start with levetiracetam. There's been a long-standing history, though, in epilepsy of these kind of alternative remedies, you know, back from the Roman Greek days on to now. And it maybe isn't quite the same as an unproven therapy, but because there is some evidence, of CBD being effective for seizures. But one thing you run into very frequently these days is CBD oil. And patients really want to see if that will work for their seizures. Well, caution, they should not resort to only taking that. There have been some cases of people who actually ended up dying from seizures who tried to go the all-natural route. It's different if they have the prescription grade. It's a very high level of the medicine in the body. But in general, you want to have people on a real anti-seizure medication and not just have them taking some over-the-counter supplement or something. That would definitely not be sufficient long-term. This is a little historical perspective back to my my Roman quote. So back in the old days, there was this kind of popular myth that gladiators' blood and kind of liver and stuff like that might cure epilepsy. And of course, there were other physicians who actually had quite a good understanding at the time of what was going on. And we're saying, it's not, that kind of stuff. It's more herbal remedies, what they had at the time, the best they had. But there's always been this tendency with epilepsy, because it does have a kind of this connotation historically of being kind of a spiritual disease and everything, to consider these sort of bizarre treatments. And, overall, I would discourage patients from trying non-proven treatments. And back to the mind body, I would mention that Studio E is something being done in town here. It was great, particularly for children, to do some of the mind body and arts kind of related things with the epilepsy community. And I would encourage you to think for your patients what resources might be available for them of that nature, especially as COVID hopefully resolves and we can get people back out there more. A big topic in epilepsy is sudden unexplained death in epilepsy patients, called SUDEP. You have to be aware of this as a practitioner. People who have epilepsy may stop breathing or have cardiovascular failure secondary to large generalized tonic-clonic seizures, and sometimes other types of seizures. And this is often manifests as people just being found, unfortunately, deceased in their bed without any other clear cause of death on autopsy. Sudden unexplained death in epilepsy patients is very much a worry of mine. It's something that puts these patients at 20 times higher risk of unexplained death than the general population. The most common cause of this is uncontrolled generalized tonic-clonic seizures. That's the big risk factor. There are other risk factors, but that one is by far the most important to think about. And so it does give you a sense of urgency if someone's having uncontrolled generalized tonic-clonic seizures, to make sure you're doing your very best to get them under control. The other important last thing I'll leave you with on this topic is that it affects about 1 in 1,000 adults with epilepsy per year. So that gives you a sense of how common it is. Relatively common when you think that's per year. Here's some other secondary risk factors I didn't go through as heavily, but nocturnal seizures is one worth making note of, and also being in a young male patient is a high risk category, meaning a young adult. Children are in general of less risk for this than adults. This was a gentleman, Cameron Boyce, that was a Disney actor who actually had epilepsy and did pass away from sudden unexplained death in epilepsy patients, or SUDEP, and it made the news and kind of brought some public awareness to this phenomenon. So now let's get into the different types of epilepsies a little bit here. We're going to start with temporal lobe onset epilepsy. Often this is kind of something that begins as a young adult. It's very common. Around 2/3 of the focal epilepsies are temporal in origin, and then mesial temporal is definitely the most common. That means hippocampus. That may be because the hippocampus only has 3 layers. It's a bit different cortical construction. It's a bit older area of the cortex. It's thought to be than some of the others. And there are many risk factors. Scarring of the hippocampus, low-grade tumors, cavernomas, autoimmune causes have become more and more of a topic worth discussing, and also just post-traumatic causes and post-infectious like HSV, encephalitis often leaves people temporal lobe damaged, and subsequently they then may develop seizures. Here's an example on the right mesial temporal region of mesial temporal lobe sclerosis, and you see it's kind of shrunken on that side compared to the left. So what are the symptoms you're looking for? The deja vu aura is a big one, especially with mesial temporal onset. Butterflies in the stomach, the weird feeling. Sometimes people have a sense of fear or anger because that region, that network is so close to the amygdala. And that can be a little bit confusing when you hear that, but keep that in mind. And if you have a left temporal lobe onset, you typically do lose language and then consciousness. You may have more awareness that persists with right temporal lobe onset seizures. It's very common to have oral automatisms or kind of this lip sacking, or you may have picking behaviors and that sort of thing, which is the ipsilateral manual automatisms. Often that's on the same side, the ipsilateral side, as the seizure onset, interestingly enough. And then it may progress. If it continues, you may end up, with contralateral dystonic limbs stiffening, that sort of thing, and could progress even all the way to, a generalized tonic-clonic seizure with, secondary generalization as it spreads out to the whole brain. And so here's a quick patient case, a 51-year-old woman, right-handed, didn't have any known risk factors for seizures, and then began to have seizures. And she just described them as an odd sensation that washes over her with a sense of deja vu. And then she would often get this feeling of angst, and then she'd have impaired awareness, and it would actually progress to the bilateral tonic-clonic semiology at that point. And then was also having probably just a lot of staring spells she wasn't even really aware of. And then here, is an example on the lab of a seizure starting. And this is something that, we captured the epilepsy monitoring unit and proved this was a seizure. These were seizures. So if you have a seizure that's coming from the temporal lobe, but it's not the mesial temporal lobe, then it's called neocortical. And that has to do, again, back to the cortex. The new cortex has 6 layers. We're talking about the 6-layered part of the temporal lobe. This can have some subtle differences from the mesial temporal presentation. And same kind of things can cause it. There's some genetic causes that are known, but the big difference is that there's often a more rapid spread to more diffuse networks of the seizure when it starts in the neocortical temporal lobe region. So there are some differences as well, depending on where in the temporal lobe this occurs. So in the anterior temporal lobe, it may actually look very similar to mesial temporal onset. When it's more of the dominant lateral temporal lobe, you may have auditory auras because that's near the auditory cortex and very rapid onset of aphasia. And then the temporal occipital is actually one of the more curious areas of onset because people can have vertigo, and also they can have very well-formed visual auras. And that's always interesting to hear when patients have those. And then, they often also have this staring, and they may progress rapidly to have clonic jerking of the contralateral face and arm. And then they frequently do generalize. Then we move on to the frontal lobe region. The frontal lobe, as you can tell from this picture, is a lot of real estate. So you can get a lot of different types of seizures from this area. This is the second most common localization of focal epilepsies after temporal, about 25%. So still not as common, even close, but it happens. These ones are easy to miss because they look a lot like psychogenic non-epileptic attacks. And that's something to just that's a big take-home point. They're often nocturnal, not always. They occur out of sleep quite frequently, and they typically have a pretty short duration with a rapid return to baseline. And the symptoms really depend where in the frontal lobe region they begin. If you begin more anteriorly in like the frontopolar region, you typically get more of this hypermotor phenomenon with, I should say, bicycling, thrashing, so these kind of asynchronous movements. And that can be really confusing when you're trying to compare this to a psychogenic non-epileptic attack. And then if you move back, as you move back and to the more towards the primary motor cortex, you tend to get more like versive head movements, vocalization, unilateral tonic or clonic posturing. You may get aphasia if it's on the dominant side. And so, it does depend on where it starts. But one of the big take-home points is just if you have stereotyped nocturnal events, you really want to consider this as a possibility if they sound kind of bizarre, that maybe it's actually a frontal lobe onset seizure, not some type of psychogenic non-epileptic attack in that context. So this is just an audio clip of someone having a frontal lobe seizure, and all they do is scream and laugh. So hopefully that got your attention. But so with HIPAA and stuff, I couldn't really show you the actual image, but that was the main manifestation, was just a patient making that vocalization with this seizure. And, again, happening very in a stereotyped manner, seemingly out of nowhere, brief duration, could occur out of sleep. These are the clues. Parietal lobe onset, on the other hand, probably much more obvious, how it starts, sensory symptoms, tingling, that kind of thing. Very common. You can rarely actually even get it like a neglect syndrome where you kind of neglect the left hemibody. But parietal lobe's typically going to be sensory onset sort of symptoms. And it's about, it's really uncommon, about 2-3% of epilepsies. And tumors are a really common cause of these, unfortunately, like glioblastoma, stuff like that, or other tumors. And so something to always think about if you start to see this. It's going to be the contralateral sensory symptoms. Now, one of my favorite topics of epilepsy is actually occipital lobe epilepsies. These can really present in curious ways as well. It's about 5% of epilepsies, maybe actually less, maybe more about 3%, depending on the source. And it's about equal in males and females. You have some of these kind of idiopathic, probably genetic forms that start in childhood. And you often, as adults, get them more from symptomatic reasons where people have, structural lesion of some type. So what are the symptoms? They're going to be visual, right? It's occipital lobes, visual cortex. Commonly, these are geometric objects that are brightly colored, and they actually move in the visual field. And they may be quite stereotyped. They may have some associated visual field loss with this. And there's often a subtle kind of tonic deviation in the eyes in some patients. And the confusing part is an orbital kind of headache is very, very common. And these are some drawings of what the aura, or what the visual symptoms rather, can look like to some patients who just drew it out. And the reason I said the headache part could be confusing, though, would be, there may be some confusion regarding migraine, how that might overlap with this. And I'll touch base on that in a second. Depending on where in the visual cortex the seizure starts, you may have some slightly kind of different spread patterns. Notably, the ones that are below what is known as this calcarine fissure that sort of divides the occipital lobe may spread to the occipitotemporal region. And what's so interesting about those is you can get this complex visual hallucination you start with these lights that are, these objects, these geometric objects are brightly colored, moving around. Then it progresses to potentially a very well-formed visual hallucination. And so that's worth keeping, in your back of your mind, because you tend to think more sometimes about like psychosis and things like that with well-formed visual hallucinations, or could it be like some type of Lewy body dementia or something like that? But seizures can also cause that. And here, if I can get this to play, this is a patient in their own words what they were seeing.
I'm seeing about 4 circles of flashing light, and at least 2 more of me. And I can see me lying from about here up. The lights are red, yellow, blue, purple, green.
Okay, so what she was describing is seeing flashing lights and then seeing herself from about waist up looking back at her. And this was happening repeatedly, and it admittedly sounds kind of wild when you first hear this. Keep in mind that when it's real stereotyped, like a spell, just lasting 30 seconds to a minute, this is probably more likely to be seizure than something else in this kind of scenario where it's these brief episodic events that are very stereotyped. So now on to migraine. Briefly going to touch base on this. Migraine typically has symptoms that last longer. The aura lasts like 30 minutes, and seizures typically are short. Typically more of a scotoma with migraine. So those are the take-home points to help differentiate them out. And sometimes you may need to refer to neurology to really differentiate that out. Here's kind of the epilepsy on the left and migraine on the right in terms of the visual symptoms. And thank you so much for your attention. Here are some of my works cited. I would be happy to follow up with anyone about any questions you may have, answer any questions, and I just appreciate your attention and mostly your interest. I'm Dr. Jake Mckay. Thank you again. Okay, well, thank you everyone for your attention. I received some excellent questions from Dr. Beth Ballantine Furman, and I'll start to answer those. And if any other questions come to mind, feel free to go ahead and type that in. So the first question was, do we have an epilepsy monitoring unit? And the answer is yes, we do have one. Since I've come in, that's been a big goal of mine, is to get that started. And we do have that running, and it was stop and go with COVID for a while, but it's running again now. The main purpose of our monitoring unit is really spell characterization, meaning, we're going to try to sort out these different things. Are they seizures, or are they some type of other spell, like a psychogenic non-epileptic attack? So we're not so much doing pre-surgical evaluation in our unit now. It's more of that purpose. Another question was, how does drinking alcohol affect seizures? Well, it actually can affect seizures a lot. People who have generalized epilepsies in particular, especially juvenile myoclonic epilepsy, it may be really provoking to drink alcohol. And then for any type of epilepsy, if they're drinking a lot of alcohol, it can certainly be provoking of seizures, either on the way up or on the way down after they've kind of withdrawn from the alcohol. That can be very provoking. So certainly it's something to limit quite a bit in patients with seizures. I have had some patients that only seized when they were drinking. So it is a sort of variable case by case, but in general, it's a good idea to avoid excess alcohol use in these patients. Then there's a question that's a very good one about the ketogenic diet. Do we use that in these patients along with the anti-seizure medications? Well, what I would say is that it's very hard to follow a strict ketogenic diet in sort of the old school epilepsy literature they're talking about. It can be tried, especially with people with very, very refractory epilepsy. Often people who are, good candidates might be kind of getting tube feeding, stuff like that. But to build on that, there's a lot of new research coming out about gut microbiome health and epilepsy. So there's a renewed interest in this. And so there may be some utility to kind of the more modern ketogenic diet, modified Atkins diet, and also having good gut microbiome would portend that maybe, having probiotics might be helpful for some of these patients. And there have been some small numbers, studies that have come out that have suggested this, that have been really impressive. There was a review article in Epilepsia last December that went through all this, and it was very interesting. So I do think this is an area to keep an eye on for sure. And then another question was about different seizure type of auras and some of the migraine patient kind of auras and how to differentiate that out. I did go through that a little quickly at the end of the lecture. So the big thing is that the epilepsy occipital lobe symptoms are often more vividly colored objects, like circles that are like red, blue, and they move. And the migraines tend to have more of like an achromatic aura, so like flickering, flashing lights, or the scotoma, where there's just a visual field kind of, or just not even field, just a central visual field deficit there. It is sometimes tricky to tell them apart, though, and it's when you hear history, it's not always that clear cut like it is in the presentation like this. So sometimes you really just have to do further investigation. Things that would definitely get my attention, though, would be if it's filled in colored objects or geometric objects that are very kind of stereotyped, and each time is pretty similar. And also if that then progresses to a well-formed visual hallucination, that would suggest that maybe you're getting a spread of a seizure into the temporo-occipital region on the left. And so that is something to really think about. And I think, you just have to keep an open mind when you hear the story to really delve into it and take it seriously with those. And sometimes the treatment ends up pretty similar. If they end up on Topamax or zonisamide, it may end up kind of a similar treatment, but it can be very difficult. And then there's another question about olfactory auras. And I do think that if they have an olfactory aura, it's probably worth investigating with an EEG. And one last question was, what is the role in primary care for starting AEDs? That's always, tricky. I think if someone's had a very convincing course of 2 clinical seizures or more, they've had lateral tongue biting, or, they've had this very stereotyped semiology with staring and stiffening, I would go ahead and start them on something, probably levetiracetam or oxcarbazepine, depending on what you're finding, and then go ahead and send them to neurology from there. If you're not sure, though, and it sounds like it could be something else, you may want to send them to neurology before starting something. If you have a high suspicion for a psychogenic non-epileptic attack. But I think that's about the time, but thank you so much for the wonderful questions and your attention. I hope this was interesting and of use to everybody, and I'll be happy to answer any further questions offline at any point. So thank you again.